I would like to express my apologies on behalf of Dr. Vaina, who could not be here with us because of an emergency case in the cath lab. And I'm going to do the presentation on her behalf. It's her presentation. My name is Drin, I'm her colleague. Without any further delay, patients with severe aortic stenosis, irrespectively of their
Παρακαλώ να κάνετε
fraction
λίγο, δεν έχετε κάνει share την οθόνη σας. Share screen.
Okay. Τώρα μεταξύ.
Τώρα θα σας πω. Ναι, προβολή, τέλεια. Okay. Ευχαριστούμε.
So, the severity of the mitral regurgitation increases with the degree of the impairment of the left ventricle ejection fraction. And as far as we can tell, there is a vast majority of patients with severe aortic stenosis who are candidates for TAVI, who have concomitant mitral regurgitation, and this contributes to a low gradient pattern, the pathophysiology behind of which we will explain later on. The guidelines of 2021 regarding the multivalvular heart disease mention that the decreased stroke volume due to mitral regurgitation is a very common finding in patients with severe aortic stenosis, and the pathophysiology behind that is that we can see that the volume pressure loops are going on the right, and that the reduced afterload causes a low flow status, and this is the reason why we underestimate the aortic stenosis severity if concomitant mitral regurgitation is present. 1/3 of the patients have both valvular heart diseases, and after performing TAVR, almost 50 to 70% of these patients have improvement to their clinical status as well as to their mitral regurgitation. We all know the classification of Carpentier and the classification of the mitral regurgitation to primary and secondary, and we should point out especially the fact that patients with normal ventricular dimensions and systolic function may have significant heart failure symptoms, and that the atrial mitral regurgitation is an entity that is most likely to be better after the TAVR procedure. This is a review of 32,000 patients, where we can see that almost most of the studies included patients with a moderate plus mitral regurgitation, and the women in the study were approximately 50% of them. As far as the studies are concerned, we can point out the fact that the risk of in-hospital mortality increased in 51% of patients with mitral regurgitation pre-TAVI moderate or more than moderate than in patients with lower degree of mitral regurgitation. And the risk of mortality is greater, the greater the severity of the mitral regurgitation is. From this analysis, we can see that 36% of patients had an improvement of their symptoms in 1 week, and 44 of them in 1 month's time after the TAVR procedure. As far as the progression of the mitral regurgitation after TAVI is concerned, we can see here that the pattern has a great heterogeneity, and the fact that the proportion of patients with moderate mitral regurgitation compared to the post-operative evaluation is quite different. And only 4.5% of patients had severe mitral regurgitation after the TAVR procedure, as if they had moderate before. So patients who had the mitral regurgitation, which was moderate or more, their progression of mitral regurgitation did not associate with overall mortality, but it associated with rehospitalization for acute heart failures and also all-cause mortality. As far as this analysis is concerned, we can point out the fact that the post-procedural mitral regurgitation was the only variable who was associated with an increased risk of 1-year mortality. And from this diagram, we can point out the fact that, yes, patients who have done the TAVI procedure and also have mitral regurgitation versus those who do not have mitral regurgitation are in more danger of congestive heart failure, of mechanical support, and also of a new acute myocardial infarction. Sorry. As far as the clinical prognostic factors are, okay, I'm sorry for that. The echocardiographic factors are concerned, we can say that the calcification of the mitral annulus as well. I'm sorry. Can you see my? Is it okay?
Ναι, μια χαρά, μια χαρά.
Okay, thank you very much. The mitral leaflet calcification as well as the mitral annulus calcification and the diameter of the annulus are the factors that are mainly associated with the progression of the disease and how it is changed after the TAVI procedure. A thickened mitral valve and a large mitral valve annulus induced by high end systolic wall stress were correlated with post-existing mitral regurgitation. The guidelines depicted that there is an option for a staged procedure of the TAVI procedure and also of a potential mitral regurgitation procedure such as the TEER. And here we can point out the fact that when we assess the mitral regurgitation and there is severe one, we should assess whether it is likely to improve after the TAVI procedure. If there is a possibility of improvement, then we perform TAVI procedure and we consider the transcatheter mitral valve repair. If there is no improvement expected, then if it's a feasible one, the mitral regurgitation transcatheter procedure, we perform TAVI again. If it's not a feasible one, we should consider surgical aortic valve procedure, or whether we are doing a TAVI or a medical treatment only. This is a case of a patient who had a TAVI procedure and using the TOE, we're guiding the TEER. We see here the clips of the mitral valve. And here, from this review, we can point out the fact that 6 months post-TAVI procedure, we can see that more and more patients are having also a mitral TEER procedure, as to the past when the patient had more time between the TAVI and the potential MTEER procedure. In patients who had an MTEER after a recent TAVI versus no previous TAVI, we had a higher risk of 30-day all-cause hospitalization and also heart failure-related hospitalizations as well. There is, here we can see that the 2 years clinical follow-up, that there is a significant improvement in mitral regurgitation and NIHA class after TEER procedure than in patients who had only medical treatment and no procedure for the mitral valve. And in patients with degenerative mitral regurgitation, a lower incidence of the composite outcome and heart failure hospitalization was observed in the TEER group than in medical treatment only group, especially for patients with degenerative mitral regurgitation and not functional. As far as in-hospital complications, acute kidney injury and vascular complications are concerned, and as well as the need for a pacemaker, it is true that there is a higher likelihood of them after the procedure is done, the combined procedure of TEER and TAVI, greater than a stage procedure, than when a stage procedure is performed. Also, the hospitalization of the patient is quite a few more days, from 4 to 15 days if a combined procedure is performed. In conclusion, we would like to point out the fact that increasing in mitral regurgitation severity reduces the transvalvular aortic burden, and this is the reason why sometimes there is a delayed diagnosis of the severity of aortic stenosis in patients who have both valvulopathies. And TAVI often results in an improvement of preoperative mitral regurgitation severity after the procedure. This is a better clinical outcome for the patient. And also, in the future, we should focus on the fact that there are differences between functional and degenerative mitral regurgitation and explore our potential benefits of a combined MTR and TAVI procedure, as well as the right time for this procedure, whether a staged approach is a better one for our patient. Thank you very much for your attention.
Okay. Thank you very much for your presentation. Are there any comments from the moderators or the audience? So I can understand that the problem is difficult, and the main problem is when we intervene in both valves or in just one valve, and the problem is even more difficult for the surgeon because they open the chest. He needs to know whether he will change just one valve or both valves. Dr. Bouboulis is a cardiac surgeon, and he talked about he gave his point of view about this topic.
Organizing committee for